Now we'll move on to our international speakers. Before I introduce the speakers, there is notice to the participants. You will be given 15 minutes discussion period after every speech, and you are invited to ask relevant questions. Our first international speaker is Mrs. Rebecca Harding. Mrs. Harding is an Australian physiotherapist who obtained a Bachelor of Applied Science in Physiotherapy from the University of Sydney in 1996. After working in many fields of physiotherapy in Australia and the United Kingdom, she established Australia's first scoliosis-specific physiotherapy practice in 2013. Before becoming the Director of Scoliosis Physiotherapy Melbourne, she obtained many qualifications in scoliosis. Mrs. Harding is not only a qualified practitioner in scoliosis, she is a qualified Pilates practitioner too. She was a Pilates instructor, course provider and examiner for the Australian Pilates Methods Association. I cordially invite Mrs. Rebecca Harding from Melbourne, Australia to deliver her speech.
Hello, thank you so much. I'm hoping you can hear me okay. Thank you for that very interesting history. That was fascinating to listen to. So I am going to be talking about conservative management of idiopathic scoliosis. And I have 45 minutes. I have 45 slides. Unfortunately, I could talk for 45 weeks without stopping, but I'll try my best to keep things moving along. All right, so basically I'm going to be covering what is scoliosis, going to talk about how to measure Cobb angles, talk about some of the signs and symptoms and how to tell the difference between functional and structural scoliosis. We'll talk about the prevalence, etiology and progressive factors. And then, of course, speak about the treatment aims and recommendations. And I'm going to be bringing a lot of case examples throughout and then summarise at the end some of the key take-home messages. All right, so what is scoliosis? Okay, so it can be defined as a three-dimensional torsional deformity of the spine and trunk. Okay, and now just before going on, I want you to just know that that spine hasn't gone over there by doing a shift and then a turn. I just want to spend a moment to talk about how that spine, the spine itself, actually got over into the that position that's not straight. Now, the vertebra itself, actually, there's two things happening. The vertebra itself actually turns, okay, on itself, but the location of that vertebra in space, it actually goes through this arc motion. Okay, so the vertebra, just so we're talking about the thoracic vertebra, it actually, as it's turning, it actually moves forward a little bit as it goes out to the side and then it comes back. So the vertebral location actually goes through this arc, okay, and that's how it gets out there, all right? So then if we took an X-ray of that spine, the Scoliosis Research Society says that we can confirm and say that that spine has scoliosis if we measure a Cobb angle of 10. So what is this Cobb angle? Take our eyes to the apex of the curve, and that's usually the vertebra that's the most translated, okay, and it's more accurately the most rotated, okay. And then what we need to do is, if we're going to find this top line, we need to take our eyes to the superior end plates and we look for the vertebra that is the most inclined away from the apex vertebra, and we draw our line along the superior end plate, okay? And then as we're coming down to find this bottom line, we're going along the inferior end plate of the vertebra that's the most tilted away below the apex. And where those two lines bisect, that is the cob angle. So we all know about all the asymmetries we can see with scoliosis from the top. Okay, we can see the ears aren't in line. If we look through the shoulders, we can see there's an asymmetry there. The shoulders, this inferior angle doesn't look even. We can look at the shape of the rib cage. This young girl looks quite full on one side, okay, and drawn in on the other side. We often see the waist is asymmetric, and also sometimes it might appear that there may be a leg length difference, but you have to beware, because the scoliosis can play tricks, and sometimes we think there's a leg length discrepancy, but there's in fact not. So I just want you to have a look at this person here. And I want you to try to see if you can work out where this person may have a curve or two. Okay, so just having a look, if we think of the shoulders here, if one shoulder is lower, it may indicate there's a concavity in that thoracic area, okay, where it's a closed area, so it may have that shoulder lower into it, okay. It may be that if you see a waist crease, again, that's sometimes a telltale that there may be a concavity there as well, okay. If one waist appears a little bit flatter, but the other one drawn in, all right. Now back up to thoracic, you can see it appears to be a little fuller on this right thoracic side, perhaps. Okay, and remember that we don't just look at the back and look at the side profiles, but when you look at the front here, you can see here that this section of rib cage on the front left appears more prominent, more forward than the rib cage there at the right anterior chest. And so that's a bit of a telltale, because remember that as the vertebra is arcing around in space, it's also rotating. So the rib cage gets drawn back on the right. Okay, in this case, it would appear it's back on the right because the rib cage at the front has been drawn back, and on the other side, it's taken forward. So it's a bit suspect here that this person has a thoracic curve, and then there may be something going on. So I'm going to show you, and I want you to think if this curve is mild, moderate, or large. Okay, so I'll show you now. And no doubt this has taken you a bit by surprise, and hence I've used this as an example, because if you see what you think may be small asymmetries, the body actually hides it very well. So like in this instance, her curves are up into well into the 60s, but really looking at her, she's actually quite balanced. Okay, she's got two curves, and here on the x-ray you can see this convexity here, how all the ribs are splayed apart, but in the concavity here on her left side, they're all close together. And here again, you can see that waist crease where it's drawn in, but also there's rotation going on back on the left and forward on the right there, and that's what also makes that crease a little deeper there. Okay, but you can see here an example that it looks like she's got a right lower leg, a right longer leg clinically, but actually looking at her x-rays, her legs are exactly the same length. Okay, so when you see asymmetries, you then need to work out, like if we haven't got an x-ray yet, we need to work out whether they're, the asymmetry is to do with the spine are structural or functional. So we do the forward bend test. And it's a good idea to always do this on a seated position, okay, to get rid of that if there is a longer leg. So we do a seated position. Now, when you take the person to bend forward, what we're looking for is if there's a prominence, so looking clinically as when she bends forward, is there a prominence on that right side, and does that prominence measure 5 degrees or more on your inclinometer, okay, or scoliometer. We also need to see that the line of the vertebrae, the spinous processes, also get drawn towards that convexity. And there's a third secondary criteria. If we looked at this case from the side, if we looked at her from the left, we might see her forward flexion arc is actually, it's plateaued, and it's there's a loss of flexion arc in the scoliotic region. Okay. So really, we've got this, if we don't see anything when they bend forward, it's considered functional, okay? And it might be from postural habits that they've got an asymmetry. But if we do see those indicators in the forward bend test, we then have to investigate a little bit more, okay? So 20% of the time when we see have a positive forward flexion test, 20% of the time it's due to a recognized medical condition. Okay, so there's all your neurological disorders, it could be some of your connective tissue disorders. There's a whole lot of conditions that do have scoliosis as a part of their condition, and that does it 20% of the time. But in 80% of the time, when we see a structural scoliosis, it's not from a known medical condition, and the individuals are actually healthy, okay? But the word idiopathic, idio means unknown, pathic means pathology. So it's just that there's unknown pathology. We don't know of any pathology. The person's healthy, okay? And this is the situation 80% of the time. But just because it's the majority, we have to be careful not to rush to diagnose it as idiopathic. It's very important to rule out the other medical conditions. Okay, and it is also important that just because somebody doesn't have a known medical condition and we put them into the group that's called idiopathic, it doesn't mean that they're all of the same, have the same driver to their curve. Okay, and this is where this group that we call idiopathic, it's not really thought of that it's all one type, or there's one that they're all the same, okay? Because we know that in this group, there are some individuals that are very hypermobile, but then we know that there are others that are very, very stiff. And then there are others that maybe have, vitamin deficiencies or vestibular issues, but then there's others that not. So it's quite an eclectic group. So even if somebody has been defined as having idiopathic scoliosis, it doesn't mean that they're all the same. Okay, but there are some things that we do know, and we know that generally this idiopathic type presents during one of the periods of rapid growth. Okay, and there's the infantile if it presents under the age of 3, a juvenile if it happens between 3 and 10 or years of age, and then the adolescent idiopathic scoliosis is the most common, and it comes on any time when there's the growth spurt. Okay, so it usually is initiated with the growth spurts. Okay, so now, progression is also much more common in girls, okay? Now, when we pick up scoliosis in kids, and if we are finding it early and the curves are only measuring between 10 and 20 degrees, it's nearly a 1-to-1 girls to boys ratio, okay? But then the curves that tend to keep on going tend to be girls. And so by the time you've got curves that up over 30 degrees, that's pretty much a ratio of 7-to-1 girls to boys. Now, of the idiopathic, like how much does this occur in the general population? If you took 100 adolescents and just say we x-rayed them all, we would find 2 or 3 of them would have scoliosis. But it's only about 10% of those cases that it actually progresses on to require some kind of conservative treatment, and it's about enough to require surgery. So what are we thinking? We've got lots of ideas, there's lots of questions. It's generally considered to be multifactorial, okay, and that there's some genetic predisposing factors. And it's interesting because we do see in cases of identical twins where both kids may have scoliosis, but then there may be only one kid whose scoliosis actually goes into progression. So it seems that there's some genetic, but also some environmental factors. Okay, and we could talk for a long, long time about all of these things, but that's for another day. All right, so now, even though the precise or combination isn't really known, we do accept that it's a torsional condition, okay? It's a torsional condition that affects the alignment in 3 dimensions, okay? And also we accept that it's a vertebral body growth disorder, okay? And this, what we see is that, now there's a couple of things here to discuss, okay? We see quite a bit. First thing you'll see, I've got written here, relative anterior spinal overgrowth, okay? And this is what we do see in scoliotic vertebra. Okay, now I've highlighted here, I've circled here, if you just look at this person's side view, okay? And can you have a look at the shape of the vertebra? Now we know that thoracic vertebrae are usually maybe slightly lordotic, a little bit wedged, with the back part being taller than the front, mildly, okay? But you can see where I've blown up there on the left, okay? The front, if you can see that, is taller than the back, slightly, okay? It's like that shape. All right, and that's we find that there is an overgrowth of the anterior part of the vertebra, okay, and so we've got, as this vertebra, it becomes lordotic, so it is moving forwards in space, and we've got this structural change going on, okay, and that relative anterior spinal overgrowth is the reason that when you bend the person forwards in that forward bend test, the Adams test, why we get a loss of that flexion arc, because it actually becomes a little bit structurally lordotic. Okay, and so as the vertebra continues to travel around in the arc, like here on the right, so now we're looking in the frontal plane, okay, and the whole front part of the vertebra has come around, so now it's appearing on the side here. We can see it's taller than at the back as we've come around. But also over time, what we get is we actually then get some lateral wedging as well from this asymmetry. And we then find that we actually get this lateral wedging where in the concave side, the vertebra is shorter, and you can see it clearly here, than on the lateral. Okay, so if we held that vertebra in our hands, it would actually be obliquely wedged, okay? All right, so during growth, curves can progress very, very rapidly. Okay, and here's an example of a girl that I saw. She was 14 years old. And the mum noticed a prominent hip, and the practitioner that she saw did organise an x-ray, but then said it was mild and don't worry about it. And this girl had just had her first period 3 months before, and girls usually, you know, they've gone through their peak of growth in that 6 months or more before getting their period. So she's growing very, very quickly and still growing. Usually girls grow for about another 2 years after menarche. So they came to me 4 months later and said that mum said her posture's getting worse. And so I organised another x-ray, and here you can see where she had come to in just 4 months. Okay, and here's another case of a young boy whose mother actually had scoliosis surgery, and she saw an asymmetry, and the GP organised an x-ray, but there wasn't any scoliosis found. 2 years later, the mum said that the but when he bent forward, the asymmetry looked much bigger. Mum to not be worrying and don't think about it anymore. Now, the thing is that the GP only looked at the X-ray, and if you look at that 13-year-old X-ray there, technically there's not 10 degrees, so it's correct following the SRS definition that there's not scoliosis if you're looking at the X-ray. But on the forward bend test, there was a clear asymmetry, so there certainly was torsion happening. Okay, and then he was not followed through because the doctor felt that he would have already, that there should have been something on X-ray, and it was only that he had a sporting incident that he ended up 2 years later having another X-ray, and here we can see just that the curve has progressed 38 degrees in that 2 years. And so when they went back to the GP, unfortunately, then he said that they'd better have it was too late for bracing and conservative options, and they went and had to have a surgical opinion. So the take-home message from this is make sure that you're always looking at the body, okay, and not just the X-ray. Because of this torsioning, you can often get you get this. That's the best way to see if there's a structural change going on in the spine, and it's not always equaled with a big lateral component. Okay, so really when there's a positive forward bend test, there should be regular monitoring every 3 to 4 months. Okay, so progression happens through the growing years, but also when you finish growing, some curves actually just don't get bigger, but then there are some curves that actually do continue to progress. So here's a case of where, as an adult, this person, when she'd finished growing, and her last X-rays were when she was 17 years old, and it was 49 degrees back then, and the specialist at the time just said, keep strong. And so she then became quite a gym junkie, keeping herself strong. She used to do a lot of weights, a lot of Pilates, a lot of resistance work. And then she came to see me because she'd started noticing a little bit of a postural change and a little bit of lower back pain. But when I said, oh, look, that we'd better get an X-ray, she said, no, it won't have got bigger because I was told it wouldn't get bigger. And that was the advice, and that was what was known 25 years earlier. We didn't have the long-term studies that we have with us now to know that scoliosis can continue to progress after growth is finished. So so I organised the X-ray, and she was quite shocked to find that her curve was now measuring 70 degrees. Now, I just wanted to mention here, it's very, very common to have these things called rotolateral lysthesis, okay, or rotary lysthesis. And it's very common. Some reports say it's about a third of every adult with scoliosis gets these. Now, if you look at this X-ray on the right, you can see right down low here, okay, you can see there's a little bit of a step, okay, where this vertebra there, hopefully you can see my cursor, it has rotated. It just is a bit of like more than the vertebra below. And it's just a sign of a loss of the integrity at that level. And here it's important, like she's quite young to have that. She was only 42. Some of these curves are incredibly stiff. Okay, you can see how close her vertebrae are together, her ribs are together. So this gets very, very rigid here. And she'd been doing a lot of work, lots of side bends, trying to open that curve. But really, when that is really rigid, it just will pass it down further. And so I think she probably was having quite a lot of movement happening low down and really not getting into the area she was hoping to target. And that's also the case here because she was rotated back on the right. These are back view X-rays. She was doing a lot of rotation of her rib cage as she'd been guided to turn to the left, turn to the left. And And if that is really stiff, it will just rotating to the left, to the left, to the left. Contributor. Anyway, okay, moving on. So we know that progression as an adult can occur, and it's, they're not growing. So it's really considered to be just from the compressive effect of gravity on an asymmetry. Okay, and I always talk to people about their heads being like the weight of a bowling ball. Okay, our heads weigh about 5 kilos, so that's a constant down on an asymmetry. Okay, and it's generally speaking, there's been research that have found that curves that are less than 30 degrees cob, okay, so milder cobs, they're less likely to progress, but it's a bit more understandable that when there's greater cobs and greater translation of those apical vertebra, when we've got a weight coming down, they might continue to creep on a little bit with the compressive effect of gravity. Okay, but also this varies a lot, whether the curves in the lumbar or the thoracic or the upper thoracic. Okay, that's just a guideline. Okay. All right, so if we've got here a progressive condition, okay, so does that matter? All right, now what does it mean for our health and function if it's not treated? Does it really make any difference if our curve actually does get bigger? So there was this great study that caused a lot of interest, and it found that there was no evidence with mortality, okay, that there was no difference in death rates when we're comparing those with idiopathic scoliosis and those that don't have it. It found that there was no significant difference in shortness of breath between the two groups either. Though those that did have shortness of breath, they did find that that these people have much bigger curves, okay, 80 degrees cob was the main thing there. So back pain, there's no difference in the intensity or duration of back pain between those with scoliosis and those not. And the majority of both groups didn't need painkillers, but there was more frequency of back pain in those with scoliosis. Okay. No difference with the activities of daily living. There was a less body satisfaction in those with idiopathic scoliosis. Okay, so now we're thinking about our treatment aims, because the point is to alter the natural history to prevent any negative associated outcomes. So here what we want is to try to stop progression, okay, because greater than 30 degrees, it tends to progress in adult life, okay, and may cause our back pain and things like that. And if we can stop before 50 degrees, then it means we're less likely to arrive at those larger cobs that can be linked with shortness of breath. Okay, so also the aesthetic can be an aim, all right, the improving pain, improving body image, and also quality of life. Okay, so I'd better move along. All right, so our recommendations, there's a couple of governing bodies there, so SORT and the SRS, that give recommendations. So really we've got observation, we've got PSSE, so that's physiotherapeutic scoliosis specific exercise methods, we've got bracing, and then there's surgery. Okay, and what we recommend really depends on how much is there growing still happening or not, the size of the curve, and also pain or any other symptoms. Okay, so the first thing you might decide to do with someone is just observe them. So it's an active observation though. Okay, so if there's still growth remaining and we've picked up a structural curve, usually the recommendation is for having an X-ray every 4 to 6 months. Okay, and then when growth is complete, we usually do watch them for maybe with an X-ray every 5 to 7 years if they're deemed at progression risk. But even then, that's changing a little bit. Now, in an EOS, some of you may have heard of these low-dose X-rays. They're reported at being about 10% of the usual radiation of your local place. So they're good. PSSC, these methods. So the PSSC, it's a qualification that's gained from one of the recognised international training schools. Okay, and here's a list of some of them. So the one that I'm involved in is the RIGO concept, SPTS. There's these other methods as well from France and Italy and Poland and Germany. And these last two and the RIGO concept, they're the ones that are derived from the Schroff method. So all these methods all share core principles, and those are education being a big part of it, teaching the person how to actively correct in 3 dimensions, how to then stabilise that corrected posture, and how to then transfer it into your activities of daily living. So the PSSE, as I said, I'm involved with the RIGO concept. So they all vary a little bit, the different schools, but generally we're all, of course, ending up in the same, and we're going in the same direction. Because we know the direction of the scoliosis, and we're all endeavouring to take the curve out of the scoliotic region, so or direction. So basically, you need to think of a curve as having a structural component, which is made up of those bony contributions and the soft tissue restrictions, but also a postural component. Okay, so when we come to upright, we know that we're under that compressive effect of gravity. And when they did x-rays comparing adolescents lying down to standing up, when they came to standing, everybody's curve increased by about 10 degrees, okay? So what the method is that we do is it uses targeted expansion techniques, and it tries to detorsion and reshape the rib cage and the torso. Okay, it's different to usual physio. We're not doing side bends, we're not doing twists, okay, and no sets of 10. So just a comment to talk about what actually happens when you do a side bend. It's important to think about it. So here's this curve in this person in the middle here. Okay, and I want you to just look at this, you know, they've got a main curve in this lumbar region. Okay, and look at the apical vertebra and look at where the location of the side of it is. If we put a plumb line down from that lumbar vertebra, it falls within that ilium there. Now, when this person does a side bend to the left, okay, we're looking back view, which she's been advised to do to open up that concavity, you can see that the vertebrae are actually being translated further to the left. So it's actually stretching some of the muscles, they're already lengthened. Okay, so it might not necessarily be doing what you think. So yes, very laterally, there may be some stretching of some of the structures, but there's actually stretching of some structures that actually are already over lengthened. Okay. So it doesn't mean that we don't bend in our life, but it might just be that you need to change the way you cue a little bit, because it's important to be able to move, of course, but you might be encouraging a bit of a centralization of that those vertebrae as you tilt over to the left, okay? Now, just having a look here again, some curves are really, really stiff. Okay, so this middle picture has actually this person's spine with 16 degrees of traction. So this is a very, very rigid curve, okay? And you can see here on this right picture, when she's doing a side bend to the right, this is back view, we can see there's actually not that much change. It's very stiff. And all that we've actually done is wound up the curve above, okay, into more of a side bend. All right, and you can see here in that middle picture again, have a look at those vertebrae in that upper thoracic. They're actually quite wedged. So she's got a structural region happening in the main thoracic below, but also a structural scoliosis happening in that upper thoracic. So when she side bends there, she's actually, you know, going in the direction that's encouraging that that upper thoracic curve there. So there's different things that we do in our approach. Okay, we can use there's a number of different exercises, but we often really promote elongation, okay, to support an area. Okay, so like with this picture of this girl in side bending, this is probably the most I would ever overcorrect somebody. I usually don't overcorrect as much as this anymore. You can see the general idea here that areas we're wanting to open and encourage expansion of concavities, but we're doing it not by side bending, okay? We're steadying other areas and the person's trained how to do that actively as well. And then we're using different breathing techniques and we're using hands-on facilitation techniques to encourage the expansion of those closed areas, not just laterally, but in 3 dimensions, okay, to reshape and detorsion the areas that we're needing to, okay? And we bring them to upright and our postures are very stable, okay, because we're trying to build up endurance and encourage the torsioned position of the body. We're trying to detorsion, and then we're trying to develop endurance and also redefine the body recognition of this new preferred posture over the posture that they're used to. Okay. Yes, and so another part of it is so we might have people maintaining these positions for 10 minutes or more, okay? And you can see this case on the right that we looked at the start, how we've, you know, she's a very supple person, and you can see here that this closed area, she's actually really expanding, and her waist here as well, she's opening up that nicely. So she is, yeah, working quite nicely there. All right, and then bring it into function. Okay, again, there's a whole lot of things that we know where the curves tend to call the body into it. Okay, so like with this girl doing her sit-stand, we need to review her technique to make sure our habits aren't just encouraging the curve. So we know that with her thoracic vertebra, it tends to structurally go forwards and become lordotic. And you can see here how she's really leading with that thoracic region. So when she stands up, she's going into that lordosis. And again, here, this girl has a lumbar curve, and whenever she lifts her leg, that concavity the pelvis just wants to lift up into the concavity. So these are things that we need to train out, and it's what we see very often, like going upstairs. You know which pelvis will want to lift if there's the presence of a lumbar curve, and we train all sorts of functions. Look, I put this picture in because this is a girl who, it was just to show her curve was very large. It was too big to brace. They absolutely didn't want to consider surgery. And here she really, really was quite miserable. She didn't like going out. She didn't like going to the pool at all. She wouldn't. So I did some work with her, and she lived a long way away. So we did a week intensive, and then she came back after 8 months, and she'd been working very well. So even though she's still growing, okay, she's a RISA 2 on the pelvis indicator. Her curve had increased by 2 degrees, which is not considered significant, but her balance had improved. There would be quite good improvement in her aesthetic, and for her that really was very, very, had a big effect on her quality of life. Okay, so there's lots of research now on these exercise methods and their effect on all these listed things here, which is great. And there's I've highlighted ones here that are randomized control trial, because there's some of them as well. So there's more and more high quality research coming out, which is fantastic. So the other thing that is really an important conservative treatment is bracing. Okay, and again, there's lots of different bracing braces out there. So generally bracing, if a curve to 20 degrees, 50 is often when surgery is discussed, okay? If it's within 25 and 50 and there's still at least 6 months of growing, usually a rigid brace is recommended, okay? And bracing overall, there's been some good big studies come out. Overall, it's about 72% successful in stopping the curves from progressing to surgical range. But it's dependent on the kids being able to wear the brace. Okay, you really need for these good outcomes to be aiming to be up over 20 hours a day. So sleeping in the brace and wearing it for most of the day. Usually we say that you can have it off for sport, okay? And it's important, a big indicator for compliance with the brace is where if you can create a really good team around your patient. Okay, so you're all supporting the kid with the bracing. All right, now there's different sorts here. The Boston brace is a very common brace. It's quite, it has a lot of contact everywhere. It does up at the back. Traditionally, it used to be that there were pads added internally, but now orthotists try to, when they're creating the Boston brace, actually build in these pads to have extra push in certain areas. There's Rigo Chenot type braces as well, and these braces are quite asymmetric looking. They have the idea that there's contact in the areas that there needs to be contact, but there's space in the areas that are trying to be allowed to expand and open up more. So there's these expansion zones. It's a three-dimensional brace. And it's also quite known for really trying to tackle this lordosing issue of the thoracic spine. And you can see here her lateral view is very lordotic all the way up because of this thoracic curve pulling her into lordosis. And then you can see her nice sagittal alignment in the brace, these right photos, where she's got some rekyphetization happening. Okay, and that's quite a thing to create with the brace forces. Okay, and this is just a picture of, again, a Rigo Chenot type brace, but now with a lumbar curve. Okay, and you can see here that the there's a forward encouragement of this lumbar curve and an inwardness. And also the pelvis is cut open here to allow the pelvis to translate to the left, okay, which is part of what we're trying to do with a three-dimensional brace. We have a target area, and you need to be controlling the regions of the spine or body above and below the target area with opposing forces. And that's happening in 3 dimensions. So here's just a cross-section, and I'll just refer you to a great article if you're wanting very detailed information on the Rigo brace biomechanics. It's a very, very good, thorough article. So it's just showing the cross-sectional areas, how one area you're taking the spine through the rib cage in one direction, but the regions above and below are being controlled. So like here with this lateral view, there's pressure coming in on the right if we're considering just the frontal plane, but it's being controlled above at the axilla, steadying inward, and also at the lumbar inward. And these forces are also happening in the sagittal plane as well. Okay. So bracing and physiotherapy can work really, really well. I put this little series of photos here because you can see this example of 2 similar curves, and you can see what we can achieve with the targeted expansion techniques that we do, but then also the direction that the brace is taking. So we're working in the same direction. So that's why combining them has been found to have better, some superior outcomes. But it's very, very important to not overload the kid. And if the kid is the number one thing that you need to encourage, and it can't be that physio is a replacement for the bracing. If there's a progressive curve, really it's the bracing that we need to encourage. Okay, so just a brief slide. I know I'm not talking about surgery, but I just want to say that the role of physio with surgery is often about really looking after the unfused areas, okay? And sometimes some surgeries will address one curve and not the other, leave some curves unfused, okay? So really we focus on mobility in the unfused areas. Really we're trying to stabilize, have good core stability of the unfused areas, and train people to make use of their hips very, very well, and have really good biomechanics with all of their activities of daily living. Okay, there's just 3 more slides. So I'm just here wanting you to have a little look at these pictures, okay, because only one of these is idiopathic. All right, now there's a little telltale sign on this girl on the right. See, she's got a little cafe au lait spot, a little birthmark there, and she had a number of them dotted all around her rib cage. So this one on the left is the idiopathic, but this girl actually has neurofibromatosis. Okay, so just because she's a teenager doesn't mean that we can assume it's idiopathic. Okay, we need to look further. Now also here with these images. So the first thing that should nearly be considered a red flag is the fact that this person is a boy, okay? It's much less common to have scoliosis, as we know. It's 7 to 1, at least, girls to boys. So that's a little bit of a flag. Okay, now the other thing is here, you can see that his rib cage is to the right. So when we bend him forward, we would expect in an idiopathic case to have a prominence on the right. But when he bent forward, it actually was prominent on the left. And we found that he actually had a bone tumor down here in the lumbar spine. Don't ask me how it set up and had a presentation like that. But basically when he had that addressed, his mum said he was straight as an arrow afterwards. Anyway, now also this person here on the right. Now, one thing you'll notice here is that this curve goes to the left in the thoracic. You will have noticed that all the other cases I showed were right thoracic curves, and that is by far the most common curve. Okay, so the fact that this goes left, you should nearly remember that as a bit of a flag. It might be that it is idiopathic, but it's more often linked with other conditions. Okay, and she had a situation that's called a Chiari Malformation. Okay, and that's like where the brain stem protrudes down into the spinal canal and causes a back pressure of the cerebrospinal fluid. So she was having surgery within the fortnight. Okay, so just some take-home messages. All right, you need to rule out other pathology before settling with the diagnosis of idiopathic. If you see an asymmetry in a growing kid, you should act promptly, okay, because curves can progress very rapidly during the growth spurts. And don't dismiss small curves, okay? Remember that every large curve was once small. Now, think before you do any spinal mobility work, okay, your twists and your side bends. Do you really, is what you're hoping to happen actually happening? Or is what you're hoping to open not actually opening and it's just flowing on to the areas either side? So watch out for rotolateral lysthesis in adults, okay? And be sure to make sure you really build a care team around the patient. And this is important. So really look for opportunity to reach out to orthotists that are working and actually have communication with them, close communication. If there's surgeons that are overseeing somebody, make sure you reach out, and we're writing letters all the time, and we're on the phone very often with the surgeons and the orthotists, so that the patient feels that we're all communicating and we all have the common goal, and that is helping them with their situation that's going on. Okay, so Scoliosis is complex, okay? There's some things going in one direction, there's other things going in other directions because the body compensates by trying to, when it senses that there's a torsion happening, it senses it and it tries to compensate by sending the other areas the other way. So it does get quite complex. So make sure you do reach out and ask for help if you need it. Okay, I've got a few references here. I just want to thank you all for being having the interest in joining the webinar, and I'd also like to thank the organising chair, Mr. Senanayaka, for asking me, and the organising committee for all your hard work with putting this together. Okay, thank you very much.
Okay, ladies and gentlemen, now it is the time for you to ask any questions if you have. Hello.
Yes, Ravila, this is Shamil from Sri Lanka. Actually, this was very interesting and fruitful session, and I must thank for that initially. And I have a question that we got to know that overgrowth and rotational forces are very impressive. Actually, some things actually we heard for the first time in this life, right? The thing is, when we are talking about the braces, I got to know that recently they have manufactured a brace to increase the pressure, that digitally, that means using a machine to increase the pressure in different places that we need for the correction for the scoliosis. Have you ever heard about, or have you ever used these type of braces in Australia? That means that's a special machine to increase the pressure on that relevant places.
Do you know, I've heard of this brace. Is that one that you, it involves like a pump that you increase the pressure? Yes, do you know, I just only heard of that this year. So it's not, I haven't ever seen one, and there's not been any done in Australia that I know, but it does sound interesting. So yeah, I guess it could be, I mean, look, as long as it's in the right locations. I guess the thing is, with the air, you would need to make sure that it was located in a way to get the combined direction of pressure.
Yes.
Because like just say in the thoracic region, that area is, not just trying to encourage that section of rib cage forwards, but it's also encouraging it inwards. So you'd have to make sure that there was still a firm brace behind that pad of air, so that when if it filled with air, if the spine just wanted to be more lateral and push the air more posteriorly, you'd still want to make sure you controlled the direction quite well.
Yes. According to that, the manufacturers or the inventors, they mentioned that we can increase the pressure accordingly, according to the requirement. In that case, it'd be a new arena for this scoliosis management.
Yeah, well, look, if you can, it sounds interesting, and it would be worth you having a look at it and seeing the results. But I've heard of it, but I don't have direct experience with it. Yeah, and look, I guess the thing is whenever you're adding pressure, because we add pressure with the braces, they're designed with pressures in them already, and then as we go along, we can add more, in the traditional way of adding those firmer pads in the directions that we want. But you need to make sure, of course, if you're adding, that you just make sure there's space within the brace to actually receive. If you're coaxing one direction, is the section of rib cage that's opposing it, is it able to receive the ribs and the body when you press it in a direction?
Yeah, thank you very much.
Yeah, no, thank you. That's interesting.
Hello, everybody. Okay. Hello. Hello, can I ask a question? I'm Damit Rakkodi from Ragam Rehabilitation Hospital. First of all, thank you very much, madam. The first thing is, what is the validation of Schroth method in using for the treatment of scoliosis? Second one is, what is the maximum age according to the new research that we can permit for a bracing in management of scoliosis? Thank you.
Okay, good questions. I'll answer the second one first. We don't have in Australia, there isn't an age limit with bracing. It's about if there's a curve picked up. So just say there's a curve even in a 3-year-old, if it's of a size that requires bracing, then a brace will be organised. So yeah, it's not really by age limit. It's on the size of the curve. Yeah, that's the main thing I need to say there. It might be different in different countries. So yeah, so there's lots of research actually on the different PSSEs, and there's a lot of different research. I've listed quite a lot in my references there, looking at the Schroth method and also looking at some of the other methods. So all the different schools came together years ago and agreed that they would, when they would publish their work, they would publish it under the PSSE heading, so that they could combine and lift the reputation of the conservative management. So there's actually quite a lot of research on the Schroth method and on the BSPTS and the others like CIAS and the Lyon method. So yeah, there's a lot. I don't know. I can't list them all because there's thousands of different articles, and some of them are now randomized controlled trials as well, which of course is the highest quality. So there's quite a few happening around the world as well at the moment. So I did highlight 3 that are yeah, randomized controlled trials, so you can have a read of that. But yeah, there's a lot. I don't know if I've answered your question.
Thank you, madam. Thank you very much.
Okay.
Hello, I'm Shireen. Yeah, thank you so much for this very informative session on scoliosis. I have a question. I would like to know, like, for a spastic for a cerebral palsy, a person who is spastic and has scoliosis, what is the best effective treatment for that kind of patient?
Yeah, that's a very hard situation. I would say usually bracing is tried if in bracing range. I mean, spasticity is a very hard one. I'm not sure if in your area they've been looking at doing different injections to try to stop the spasticity. I have tried to apply the you know, the Rego PSSE Schroth-based approach with some cerebral palsy clients, and it's been very tough. Yeah, I mean, if you can help share knowledge on the positioning, of course that's important. But as for the exercise side of things, it's, you know, it comes down to the individual situation on how well the person is able to take on your instruction and how strong are the you know, the spastic elements of the of what's creating the curve. So I haven't got a lot of experience in that area. I'm sorry, but I don't know if that's helped.
Okay, yeah, because he's on a baclofen pump where they and they with this drug it releases the spasticity, like it get reduced, and but then the scoliosis is still there. So it's not suitable according to that patient to give a brace because he's all together on one side. He's just structural, but he can slightly move his body. He has dystonia.
Is he still growing or is he finished growing?
He is 25 years.
Okay. Look, I mean, you could try to, and is he able to follow
And he's
instructions?
quadriplegic. He's quadriplegic as well.
So he's got a lot going on.
Yes.
Look, I think you would try to understand, you know, the curve and try to have the positioning and the support with his chair.
Yes, and cushions.
And all of that positions. If he's able to follow instruction, I mean, I was going to say you could do some breathing techniques, but I think if he's quadriplegic, then that probably is maybe not an option. So I think it sounds like you're doing as much as I can think of in terms of, yes, positioning and supports, physical supports for him.
Yeah.
Yeah, I mean, there are some braces that are done in adults as well now that can help, you know, provide closer support. But again, it would depend on his level of how well the spasticity is being controlled. You know, you have to be careful of pressure sores.
Yeah, true. True.
Yeah.
Okay.
Good luck.
Yeah,
Thank you.
Thank you.
Okay, as the time is up, shall we move to the next lecture? Others, you can forward your questions through emails to the Society of Physiotherapy in Sri Lanka. Then we'll get the answers.
Thank you, Ms. Harding, for your informative lecture. Participants, now you can ask